Good morning, everybody. We are demonstrating a live surgery of a 13-year-old girl who has suffered an episode of dislocation of the patella. This is her first episode of dislocation, and it was like a dancing accident. And what you can emphasize here is there is a lesion on this part of the patella. There is a defect here, and you can see a loose body right here. So you can see a loose body right here in this area, and probably this is a osteochondral fragment which has been avulsed from the medial side of the patella, and it has gone into the lateral recess. Along with that, you can also see that there is a hyperintensity in the MPFL area. So basically, the patient suffered an episode of dislocation, torn her MPFL, the patella subluxated laterally, and because of that there is an osteochondral fracture which is there, and there is a loose osteochondral fragment which is there in the lateral gutter, and we need to treat it. Now there are many options to treat this problem. What you can do is you can do this excision of the fragment, and you can leave it like this. Some people will do an excision of fragment with an MPFL reconstruction. But I would like to do a more anatomical procedure, and by anatomical procedure I mean that I want to reconstruct or recreate the anatomy per se. So what I want to do is I want to fix this fragment per se onto the patella, and I would also like to reinforce the MPFL, and we do it by a technique which we have described and which is published, and the technique is called as an MPFC advancement surgery, medial patellofemoral complex advancement surgery, and this is published in arthroscopy journal. So what I will be doing is I will be doing a restorative surgery, recreating the anatomy. I would do a fixation of the fragment, and I would do an MPFL repair or MPFL advancement surgery, so that we address all the parts of the injury per se. So let's start with the live surgery. So episode of patellar dislocation with osteochondral fragment into the knee. Now this is our basic setup that we want to do the procedure in it. This is by and large an open procedure for me because I want to recreate the anatomy, I want to fix the osteochondral fragment, and I want to fix the MPFL. So we do it in supine position, leg hanging down, using a knee holder, so we can adjust the position accordingly. What you can appreciate here is this patella is significantly unstable. So if you just move it like this, the patella goes laterally very easily. So you can see that there is a very, so if you can see here, the patella is significantly mobile. The patella is moving like this. So significant instability, apprehension was positive on clinical examination. The MPFL or the medial structures on this side has been torn. The episode of the injury, the mechanism is a lateral dislocation of the patella with a trauma, and which has led to a fragment which has been avulsed and gone into the lateral gutter. So what we will be doing is an open surgery. This procedure is an easily reproducible procedure by most of the orthopedic surgeons, because we will be doing it in an open approach. We will be using the Arthrex knotless system for this particular case, and we will be fixing everything in an anatomical measure because she is a young girl of 13 years of age. So what we want to do is we want to recreate the anatomy, recreate the pre-existing structures in the same way where it was torn. So we want to recreate all the anatomy, and therefore we have decided this approach. So we will be doing a small medial parapatellar approach, medial arthrotomy. But as we have described in our paper, we will be doing it in a stepwise manner. So the medial structures of the knee we will be dissecting in layers, layer 1, layer 2 and layer 3. We all know that layer 3 is the MPFL condensation. So the layer 3 of the medial side is the medial patellofemoral ligament per se, and we will be identifying it separately and repairing it onto the patella with special anchors. So let's start with the procedure. We can once again see the significant instability that is there. So what you can see is this, and if you bend the knee, you can see that the patella becomes unstable. So if the knee is in flexion, the patella doesn't dislocate. So in these cases, in those patients who are having a dislocation, the dislocation of the patella is in extension. The patella dislocates in extension here. When you flex it, the patella becomes stable, and that does not dislocate because the trochlea is now working. So the dislocation is in extension, and we need to stabilize the knee in extension so that this movement we should be able to avoid when you finish the repair in the end. So this lateral dislocation should be completely obscured in the end of the surgery when we are done. So, we will be just starting our approach. So, we will just be taking a medial parapatellar arthrotomy. So, force please. So, we can appreciate here that this is the patella, this is the fascia that we are releasing. Okay, deep knife please. Okay, so you can see that this is the medial aspect of the patella. You can appreciate the quadriceps anatomy here. Okay, and this is the crease. This is between the quadriceps tendon and the muscle belly here. So, this is the vastus medialis VMO that we talk about, and this is the quadriceps. So, we will just expose the quadriceps muscle, and we will be exposing the medial border of the patella per se. And in this technique that I told you, we need to, as I told you, we need to appreciate and release the medial layers, medial layers. So, this is my first layer. So, I am releasing my first layer like this, and I will be going like this. So, this is my first layer. So, the first layer consists of the retinoculum of the extensor apparatus, and we are releasing it like this. Now comes the second layer. We are cutting the second layer as well. The second layer is also cut like this, but we should be avoiding cutting the third layer, because the third layer is the capsular condensation, and this will include the MPFL per se. Okay. So, this is the second layer that I am releasing. This goes up in this way, this goes up in this way. Okay. So, now this is basically the layer that we want to expose. So, this is the first and second layer together that we are exposing till the base. Okay. Artery please. Now, at this point of the time, we should be able to separate the layer 2 from the layer 3 like this. Okay. So, this is the layer 3. You can see that it is a very flimsy layer. It is only the capsule, and this is the condensation of layer 2 and layer 3. Hold it like this. So, this is the condensation between the layer 1 and layer 2. We release it thoroughly from the top like this. Okay. Now, just leave it. Now, this layer you can see is the layer of my medial patellofemoral ligament. This layer is the medial patellofemoral ligament, and this is a flimsy layer. Artery please. Okay. So, this is my patellofemoral ligament layer, and I separate it like this. So, if you see my artery goes down deep into the recess, and now I go here in this region. Hold it for me, knife please, and I will just be exposing it in this way. Okay. So, again my layer 1 and layer 2 are exposed. Okay. Now, this whole layer, if you can see, is the layer of what is called as the MPFC, that is the mediopatellofemoral ligament complex from here to here. So, it includes the part going into the quadriceps, it includes the part which is going into the patella, and it includes the part which is going beneath that as well. Knife please. Okay. So, now this dissection is important, and when you are doing this particular surgery, it can be done by any orthopedic surgeon. You do not need to have a knowledge of arthroscopy per se. This can be done by a standard arthroscopic surgeon as well. But the important thing is you should be very well versed with the capsular anatomy and the anatomy of the medial structures of the knee, and you should be very well versed with this dissection, because this is the dissection that I want to close and repair in the end of the procedure. So, when I am done with the procedure in the end, I should be able to repair this tissue back here. So, in the end what I would do is I would release this tissue, and I would advance this whole tissue, I would advance all of this tissue onto the patella, thereby increasing the tension on the medial patellofemoral side complex and repairing the patella in a nice way. So, again I would do the same maneuver, keep it like this. Again, if you do the same maneuver, you can see the patella is going like this, and this is the MPFL complex which is getting stretched. So, now I will be just cutting this third layer, which is the MPFL, and this will, knife please, and this will expose the hematoma. We should be careful that we do not lose the fragment may come out now. Okay, so you can see that this is a hematoma which comes out. Okay, because these are acute scenarios and there will be bleeding inside the knee. So you need to take out the bleeding, everything in one go. So just everything needs to take out. Okay, knife please, forceps please. I am doing this slowly because occasionally it may happen that if you make a big incision or a big rent, the fragment may come out. Okay, yeah, the fragment may come out and you can lose the fragment per se. Okay, so now you can see that this is the layer of the MPFL I am talking about. This whole layer from here to here is the layer of the MPFL that I am talking about, and I expose it at the level of the patella. So I'll just release this whole of this layer from the inner side. That's it. So now you can appreciate that the MPFL we have separated nicely. Suction please. Okay, relax, 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 relax. Now at this stage, the thing is we need to identify the loose body of the osteochondral fragment that we would like to fix here. To take out the fragment from my finger. So this fragment was in the lateral gutter and I have exposed the fragment from the lateral gutter by putting my finger in. So you can see here that this is the fragment that was, this is the osteochondral fragment which was fractured, and this is the fragment that I would now like to fix. Now you can see the fragment which is coming out in picture, and so it is a decent size fragment. So you can see this is the fragment, this is a very decent size fragment, and this fragment is a good size fragment which needs a mandatory fixation, because this fragment, if it is not fixed properly to the patella, this will lead to loss of cartilage and the patient will have later on patellofemoral osteoarthritis. So now it is our duty to fix this fragment back into its place. So now we have taken this fragment out and now we will be dissecting the crater from which this fragment has been avulsed. Okay. So we are good here, and now we will be just doing a good quality of lavage, everything. Knife please. Knife please. Relax, relax. We'll just do a little bit of removal of the ligamentum because we want to have a good exposure. Okay, and now knife please. We want to expose it a little bit more because we want to evert the patella to be able to fix this fragment. So I'll just expose it a little bit further. Okay, and now if I just do like this, you will be able to see, curate please. You will be able to see that this is the region and this is the defect. Small curate please. And you will be able to see, or a small artery. So you can see that this is the fragment of this is the area. So this was the area from where the fragment was avulsed. Okay. So this is my region of the osteochondral fracture. You can see that, and this is a very classical area from which the osteochondral fragments avulse. Wash le lena beta. This is the very classical area from which the osteochondral fragments are avulsed, and this needs to be fixed properly because, and you can see that this is a good sized fragment. वो अपन टी correctly use करते हैं ना पकड़ने का वो, and you can see that this is a good sized piece, good sized osteochondral lesion. So if you can appreciate here, it's a really good sized. Okay, so this is the area, and this is the central ridge of the patella. These are the lateral facet, and this is the medial facet. So basically, it is the medial facet. So basically, it is the medial facet which goes in. Okay, and this is the somebody hold it. So, and this is the basically the medial facet of the patella which is exposed. Knife please. Knife please. Soy block, please load it with anchors, and we'll just prepare it nicely because we want, and we all know that this is the thickest portion of the cartilage in the body. So this patella cartilage in this particular area is the thickest portion of the cartilage in the body. So we need to prepare it nicely. So what I will be doing is I will be using push lock anchors. The first push lock will be in this region. Go ahead, please. Okay, so this is my first push lock. You can take it out. Okay, so this is my first push lock, and this push lock I will be loading it with the vehicle and please. So this is my first push lock which will be going here, and then I will be using probably 2 or 3 push locks. So I will be loading the push lock with the vehicles. Good. So you can see that this is the push lock anchor, and we have loaded it with the vehicle suture, and we put it in this particular area where we have created the hole. Okay, and then we will be just pulling these wires into its place. Okay, you can actually tie them over to that this place. Okay, that is okay, and then you can keep it holded like this. You can see the push lock anchor here, and for the push lock anchor you just need to take this out and use a hammer to use a hammer. You can see that you can use your hammer, okay, in. So you can see that the push lock anchor is now deployed, and once the anchor is deployed, you need to rotate it anti-clockwise in this way. Okay, so take it out. So now we have 4 suture limbs which are into its position, and these suture limbs will be used in this way: one here, maybe 1 or 2 here, and 1 here, like this, in 3 places. So one will go here, one will go here, and one will go here. So I'll be using the fragment here, and the fragment will be compressed by these vehicle sutures into the side, and we will be fixing it up with the push lock anchor. Okay, now you can just take the fragment, or you can do the drilling first. So what I'll do is I'll drill the first anchor here, because this is the area which is absolutely in front of this area, the first anchor. So this is my first push lock anchor. Okay, so this is my first anchor. The second anchor will be here. The second anchor will be here. Fragment into its place. So as we have seen, the fragment was almost the fragment was fitting like this. Okay, so you can see this fragment. Okay, and the most important is the center one. So I'll put 2 sutures in the center like this, one here and one on the top. Okay, just leave it. Give me a push lock, please. Give me a push lock anchor. So we can see that this is the most important push lock anchor. And these 2 holes are loaded like this, and now we can just relax. So this is the area where I will put it, and you can see that the fragment is sitting very efficiently onto its place like this. Okay, now take this one out. Okay, so we are able to reduce it into its place, and then just tap it lightly. enough. So that's it. So the first and the most important fixation of the fragment is done, and we will be just taking it out like this, and we can see that the fragment is now sitting nicely onto its place. Okay, we are loading this vehicle like this. Okay, and you can see now. Okay, you can see that the vehicle is now reduced onto its place, and we'll just take this one out. Okay, and then we'll just tap it in. Okay, good. And then we'll just take it out onto its place. I need monocril. Okay, so you can see that the fragment is nicely sitting onto its place. Vehicle please, knife please, knife please. Okay, so the whole fragment is now sitting in a very nice manner. We'll just cut the vehicle here, both of the sides of the vehicle. Okay, force it please. And then we can do a little bit of, we can debulk the cartilage a little bit, and then there is a technique of closure with a monocrystal suture. So we can use small monocrystal sutures to actually repair the rest of the cartilage onto its place. So what you can do is, so you can see that the fragment is well set into its position. And this is the monocrystal suture, and you can use the monocrystal suture in the cartilage per se. So here we are using it in the cartilage like this, and we are closing the cartilage per se. So cartilage lesions can be sutured nicely with the monocryl. This is another message that I want to convey. So this is a monocryl suture, and you can close these cartilage lesions with the monocryl sutures like this. Just cut it, close, chota karna, chota karna. हाँ. So you can see that the cartilage is being closed with the monocryl on this side, and on this side also I'll take a bite through the cartilage. As we all know that these cartilage lesions are very, this cartilage of the patella is a very thick cartilage. So we can take a very good bite of the monocryl from this cartilage region per se. So, and then you can just close it properly. 1, 2, 3. Okay, just cut it short. Chota karna. Chota. Okay, so this is it. Okay, so this is sitting very nicely, and then one I would go from here to this region. Just cut it. Shorter. Okay, so now we can see that the fragment is very nicely fixed onto its place, and the final suture we will be taking in this region. This is the final suture. Okay, so now we can just appreciate that the fragment is nicely sitting onto its place where it was avulsed from. It sits very nicely. The patellar, whole of the patellar congruency is restored. This is the lateral facet, the medial facet is restored, and everything is restored. And now I am planning to do my MPFC advancement or the repair procedure. And what you can appreciate here is this is my medial patellofemoral ligament complex from here to here, and I would like to reduce it back onto this region to make it more stable, to make it more stronger. Okay, So I'll be putting 2 anchors on the patella and then forceps please, non-tooth forceps. So if you see here, this is my MPFC or the MPFL structure. Knife please, knife please. So if you see here, okay. So this is my layer of my MPFL, and I would like to repair this nicely onto this area of the patella so that I get a good repair and the patient can be mobilized very fast. So now this is my layer of the MPFL from here to here and to here also. So this is again the layer of the MPFL. Hold it like this. Look, I'll just cut it from here. Okay, so now this is the layer of the MPFL which I would like to repair like this. Okay, now I'll be using 2 of these fiber tack anchors, one here and one here. Fiber tack anchors, drill. Okay, so what I'll do is I'll make holes for 2 anchors. One anchor I will put it here. We all know that the MPFL is attached on the superior part of the patella, so the majority part is here and the second is here. Okay. Drill please. So you can see that the first part is we have restored nicely with the use of the knotless technique and the use of monocryl, and the second part is the MPFC repair that we are doing here. Now this is a fiber fast tack anchor. So the we will be using 2 anchors here to do the MPFC advancement surgery or the MPFL advancement surgery. This is a primary repair surgery and this is a very good surgery which I do routinely in instead of the routinely performed MPFL reconstruction surgery. Anchor please. Go ahead. No, no. Just go ahead. Go ahead. Go. Just take it out, take it out, take it out. Just one. Go again. Go again. Good. Go ahead. Nikalo. Put the anchor. So these are all suture anchors. Good. Take it out. So these are all suture anchors. Okay. So this is my first anchor. Okay. So this is a single loaded anchor and you can see it has got a very good pull out strength. Okay. Second anchor please. Okay. The second anchor goes in this region. Okay. Go ahead. So this is the second anchor. So okay. So now we have 2 anchors which are there, and forceps please. And now these both the anchors are holding the patella very nicely, and we will be using the MPFL advancement or the MPFL primary repair surgery, forceps not non-tooth forceps please. And you can appreciate that this is the layer of the MPFL which I now want to repair it. So I can use a scorpion device or a first pass device, something like that, to pass deep bites onto the MPFL or the capsular thickening. So I use a non-tooth forceps I use this one, I pull it deeply, I pass deep sutures. Okay, this is my first suture. Okay, this is the first one, and I'll take the second one now. Again, I'll take a deep bite. I take a deep bite in this area. Okay, and now you can see that this is the MPFL and this is advanced on the patella in this manner. Just hold it like this. And now I will be using the lower one. So this is my lower suture, and I will be passing the sutures like this. This is the lower one. Again, this is the lower one. So you can use your knee scorpion to pass this suture. Okay, so this is it. So now, if you see here, these two are here, these three are here. So now we will just repair this MPFL tissue like this. So what you appreciate here is this MPFL tissue is advanced about a centimeter over the patella like this. Okay, so there is an advancement that you can see of the MPFL tissue onto the patella, and this will give stability to the patella per se. So what I will do here is I will just be tying these sutures of the MPFL. I will be tying these sutures of the MPFL, and probably will be using this in a double row fashion also. I'll explain you how. So just tying the first suture like this, holding it like this, tying my second suture. So tying my second suture like this. Okay. Passer first. So now you can see here that we have exposed it nicely. We have done a good knife, please. Knife, please. So this is the MPFL. You can see that the MPFL is tensioned now. We'll do a little bit of more release to make it more pliable or mobile like this. So this looks better. Okay, and then I'll be closing this with this in a double row fashion. So what I'll do is these sutures that I have passed onto the MPFL, now I'll be passing on to the tissue on the top of the patella per se. Okay, so when you close this, you will have a very good sort of a double layer closure of the MPFL. So this is sort of a double layer closure of the MPFL, and patient will have a very good stability. We are able to restore the kinematics by doing the fixation of the osteochondral fragment with the use of push locks. We are able to do a good repair of the MPFL structures. You can just tie them like this. Okay, so you are able to close them very nicely. Okay, you can just close them. Vical, and you can see that these are closed like this. So very nice closure of the MPFL, and it is advanced and it is tensed. So once we are done with this, knife please. We just cut these sutures. Okay, and now what you can appreciate is that the structure is very tight, and you can bend it completely. You can extend it completely. It is very tense, and when I do like this, it does not go on the lateral aspect. This becomes very stable. So there is no lateral translation which was there initially. So even in full extension, there is no lateral translation, and we have not closed the first and the second layer. So the first and second layer is here. Force. So the first and the second layer is here. We have not closed it. Only on the closure of the third layer, the patella is such stable that we are not able to move it or dislocate it laterally. So this is the stability of this repair which we have achieved, and now we can just do a regular closure of the first and the second layer on itself. So we will be just closing the regular closure like this. So this is just a regular closure, just like anything else. So okay, Okay. Okay, so this is now the first and second layer. Important thing, you don't have to tension them. You just have to close them where we have erased them. So you just close them in a normal way, that is more than sufficient. You don't have to advance or tension them. The tensioning or the advancement is to be done for the third layer, and that is the actual MPFL layer. Okay. So, and then you can just, this is a regular closure that we want to do. This is just like a regular arthrotomy closure that you do. Okay. So this is my regular closure that I am doing. Correct. Okay, so this is my, again on the lower part also, I will just be closing it. And this closure will include only the second and the first layer. The third layer we have already closed, and we have closed that layer under a tension. So this is now a standard closure or the standard arthrotomy closure that we do for any of the knee surgery, like a knee replacement. And this is how we are able to close it nicely. Again, we can just recheck the stability. Sorry. So again, you can see that this is very nicely closed medial arthrotomy. The patella is very, very stable. You have absolutely no movement of the patella on the lateral side. It becomes very stable. Now we just have to close it in a regular fashion, and we have a full range of motion. So we can actually start the patella range of motion from the first day. The range of motion exercises can be started from the first day. No need to immobilize the patient. So we got a good fixation, we got a good repair. No need to do an MPFL reconstruction surgeries. Typically in these first time dislocators, you don't need to do a MPFL reconstruction, because you have actually tensioned the MPFL, repaired it nicely, it becomes tense. The stability is very good, so you achieve the stability very nicely without doing an MPFL reconstruction, without using any graft. You get a very good stability of the MPFL, you get a good closure, you get a good range of motion, and you get a good fixation of the fragment also with the knotless suture bridge technique. So this is how you should address a patient with an acute patellar dislocation with an osteochondral fragment. So you address everything of the mechanism of an injury, you address the injury of the osteochondral fragment per se, you repair, you fix the osteochondral fragments. Now these fragments are sometimes such smaller, like in this case, you cannot use a screw. It's a very, very small fragment. If you use biopins, it may cause reactions. Then, so this best thing for this kind of patients is to do a knotless fixation with Vicryl using the push lock anchors or the soil lock anchors, and then you can just repair the rest of the cartilage with the monocryl, and then you do an MPFL repair or a MPFSC advancement surgery with the use of all suture anchors, and this will give the stability which is needed. So this patella will not dislocate, that is number one, and the cartilaginous portion that is torn or the OCD fragment is also reduced on its place. Thank you.